morning, dear ladies and gentlemen, and welcome back to the second Gajah Mada ICTM 2025.
And in a few moments, we will start for the symposium forum that will discuss regarding bridging the equity gap and ensuring access to innovation in tropical disease preventions and treatment for all.
This session will be led by Dr. Aldilas Ahmad Nur Setio from Universitas Gajah Mada. A brief introduction about him, dear ladies and gentlemen. He is a technical officer for ASEAN Biodiaspora Virtual Center, a researcher at the Center for Health Policy and Management here at the Faculty of Medicine, Public Health and Nursing Universitas Gajah Mada, and he is also a consultant at the World Bank Group.
Okay, without any further ado, let's invite Bapak Aldilas Ahmad Nur Setio.
Wabarakatuh. Good morning, still morning, I think in this time. Good morning, ladies and gentlemen, participant of ICTM, and thank you, MC, for introducing me. You can call me Aldi, and I will be the moderator for this fourth symposium on bridging equity gap on ensuring access to innovation in tropical disease prevention and treatment for all. So as you attend the past, this is the third days, and as you attend the past symposium, you might see many ongoing research and innovation that have been brought up. And however, the next question is how to make sure that all people, no matter their social and economic status, race and gender, or with the disabilities, can have access to it so that we can improve the quality of life altogether. Especially we live in tropical country and also developing country where infectious disease is still a threat. So I will introduce one by one our four speakers for this session. Okay, the first one is I will introduce the first speaker for this session, the Lutfi Aziza Tunisa from Universitas Gadjah Mada, and you can see the CV. She's PhD, currently a PhD student in epidemiology and population health, London School of Hygiene and Tropical Medicine, LSTM, London and UK. And then she's a lecturer and researcher in the Department of Health Behavior, Environment, and Social Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and also researcher at the Center for Tropical Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Okay, for this first session, she will talk about equity gap among the vulnerable Indonesia and in the global context. So I think Lutfi introduce all the speakers first or one by one. Okay, so already online, Mbak Lutfi.
Hello, good morning.
Good morning. I think you can present your talk right now. Time is yours for 20 minutes.
Thank you so much.
We can see your slide right now. Okay.
Right, thank you so much. Yeah, good morning, ladies and gentlemen. It is a pleasure to be here in the Gamma ICTM 2025. So currently I'm studying on the health among people with disability. So my talk today will focus on health inequity experienced by people with disability and how the system can adapt and bridge the gap. Because this is a conference on tropical diseases, infectious diseases, let me start with a question. So as we know that tropical diseases like dengue, malaria, tuberculosis have affected millions of people worldwide. And innovation in the prevention and treatment are really advancing. But the question is, are they truly accessible for people with disabilities and other vulnerable population? So let's start the talk with equality and equity. Probably most of us already aware about the equality and equity. What's the difference? And this is very popular illustration that can illustrate and explain the best about equality and equity. So equality, as you can see in the left-hand side, is the same access to services for individuals belonging to different social groups. So it is the same access. While equity here refers to the vertical equity, meaning that individuals belonging to social groups with greater needs should have greater access to services in order to meet their needs. So with this definition, we can really understand whether our intervention that we have developed right now is addressing this equity gap or not. So let's start with what is disability and who are people with disabilities. The concept of disability has been evolving for quite some times. And first of all, a long time ago, it started with charity model, which views people with disability as object of charity. So people with disability are perceived they are helpless and need to be cared, dependent, and as a passive recipient of welfare. And then this model is shifted to medical model in the mid-19th century, which views people with disability with their impairments. So this views sees the impairment of individuals and trying to find out how to improve or how to fix the impairment that individuals have. And then it shifted again to social model in the 1970s, which sees people with disability become disabled because of the barriers in the society or in the community. So be it like physical, environmental barriers, attitudinal, information, communication barriers, and so on. So that barriers hindered participation of people with disabilities in the community. And now we have human rights base. So this is the current understanding to more understand about disabilities. So based on the UNCRPD, United Nations Convention on the Rights of People with Disabilities, people with disabilities are those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on equal basis with others. So here the emphasis and highlight is the interaction of various barriers and the condition of an individual. And now we have WHO International Classification of Functioning, Disability and Health, which in line with the human rights-based model. So here, disability can be seen as the interaction between individual health condition, which affect their body function and structure, and then in interaction with environmental factors and personal factors can hinder their participation in the community. So for example, as a person have vision impairment due to congenital disorder with interaction with the inaccessible health education and information on vaccination, and with other factors like lower socioeconomic and education, then may limit their participation in accessing vaccination. So it leads to the status of unvaccinated. In the world, there are around 1.3 billion people living with disabilities, and it is 16% of global population. How about in Indonesia? We have two different surveys with different data showing the estimate of people with disabilities in Indonesia. So from the Basic Health Survey 2023, we have around 5% adults living with disability among adults population. And then from the National Socioeconomic Survey, measuring disability using Washington Group short set, the estimation is around 2% with cutoff of a lot of difficulties. And yeah, it is among a whole Indonesian population. Now, what we know on health inequity experienced by people with disabilities, and we can also learn about the inequities in tropical diseases management as well. People with disabilities tend to have worse health access and poorer health outcomes. They are more likely to have diabetes, more likely to have HIV, AIDS, and children with disability twice more likely to experience malnutrition and die due to malnutrition, 10 times more likely to have serious illnesses, and 15 times more likely to experience catastrophic health expenditure, and 40% of the cases of low life expectation due to the reason that health system cannot accommodate the health needs of people with disabilities. And children have higher risk of common causes of under 5 mortality, such as fever, diarrhea, and acute respiratory infection, have greater risk of missing out vaccination, and adults have experience on lacking in the HIV responses, have lower uptake and access to cancer screening, and those leading to higher risk to die from cancer. This is the life expectancy gap estimates from the 12 countries based on the modeling, showing that there is really huge gap of life expectancy between people with disability and those without disability. Here, as we can see in Indonesia, we have 9 to 15 years life expectancy gap between people with disability and general population, meaning that people with disability die younger than those without disability. Our meta-analysis shows that mortality in people with disabilities twice than general population, and the median gap in life expectancy is around 14 years. So why this gap is really happening now? Because first, people with disability have the health condition. They have the general health needs like other population. In addition to that, because of their impairment, because of their disability, they have additional disability-related condition and health needs, such as the needs for rehabilitation, assistive technology, and specialist care and advanced care. And then because of the impairment, they are at risk to develop secondary conditions such as pressure sore, urinary tract infection, and so on. And they have increased health risk because of, for example, like sedentary lifestyle. They are at high risk to have non-communicable disease. And they experience delayed diagnosis, for example, due to the inaccessible information, due to the diagnosis overshadowing that see disability first before the health complaints they have, so they may experience delayed diagnosis. Stigma, negative attitude, and discrimination still exist, hindering them to participate in accessing care. And then excluding from information and access to preventive care, for example, like information is not accessible, the preventive care is not really accommodating the needs or the access that is needed by people with disabilities. These all together result in higher mortality and poorer health outcomes compared to those without disability. And what the evidence we have on tropical disease? Actually, we have very limited evidence on tropical disease. I talked to several colleges working on tropical disease among people with disabilities. So Currently, no current research to suggest that people with disabilities have greater burden and needs for malaria than those without disabilities. Similarly, in dengue, we found very limited evidence among people with disabilities. We have several on tuberculosis showing that TB incidence in people with disabilities is higher compared to those without disability. And this is from South Korea, so we have still limited evidence from the high burden country. Therefore, we have really limited evidence on tropical disease among people with disabilities, and this is a calling for research for colleagues who work on tropical diseases. So, but we can have the hypothesis. So probably it links through poverty cycle, because disability and poverty is vicious cycle. Disability can be cause and also consequences of poverty. And tropical diseases, many of them are related to the poverty. So what does a better health system for people with disabilities look like? Missing Billion initiative, an initiative working on the development of health system to be inclusive, has already developed a framework. So inclusive health service must have this component that people with disabilities are expected, accepted, and connected in the health system. So what does it mean by expected? It means that the needs of people with disability are accommodated in the health system and healthcare services, so that the health services are accessible and also affordable and accepted. When they come to the health services, the health workers accept them. The system are ready to accommodate them to access care. And then connected, meaning that after they visit the health service, they are still connected to the health care system by maintaining quality care and also providing accessible information. So this is the framework that Missing Billion developed for inclusive health system frameworks. So it started from the delivery service delivery side. People with disability imagine that the health system and healthcare service must have autonomy and awareness for people with disability, meaning that people with disability make their own decision on their health choices. And then it must be affordable, meaning that people with disability can afford to access. It also apply for like digital intervention or and other technology. It must be also affordable by people with disabilities. Human resources, health workers are knowledgeable and have the skills to provide quality care. Health facilities must be accessible, including the infrastructure and information. It's also apply if we develop the digital intervention for tropical disease as well. The accessible rehabilitation and assistive technology must be also in place, and this service delivery level has to be supported by the system level, meaning that there should be policies, there should be leadership in the health sectors, and there must be budget and adequate health insurance in place, and data, also research for evidence must be showing the health situation, particularly disaggregated by disability status. And this all together aim to have effective coverage of services covering people with disability, and the ultimate goal is to improve the health status of people with disabilities. And what about digital health innovation among people with disabilities? So the main barriers is about so this digital health can improve access and care delivery, but most of the barriers stating that these groups are often the highest risk of digital exclusion due to the accessibility and also their socio-demographic factors. So this is a call for us to, when we build or design an intervention using in technology, must be taking into account the accessibility for this underserved population. So most of the challenges are related to the accessibility, digital literacy and usability issues, the affordability and infrastructure, and lack of inclusive policy and regulation. So why actually this is important? What I talk about is important to be incorporated in the health system and policy and programs, because first of all, disability cannot be eliminated. It's part of our life cycle because it's closely related to age. All of us will age, and it is related to disability and functional reduction as well. And many health conditions can result in disability. For example, like non-communicable disease, you name it, like diabetes, stroke, and communicable disease as well. For example, tuberculosis, malaria can also lead to disability. And everyone has the risk to become disabled. So the system, the policy, the programs must take into account the needs of people with disability when it is developed. So some key takeaways from my talk is that people with disabilities have higher level of health needs, yet face greater barriers resulting in poorer health. There is limited evidence on tropical diseases among people with disabilities, which call for more research on this topic. And research and innovation must include people with disabilities in the meaningful and equitable participation, so it makes sure people with disabilities are not left behind. And considering the needs of vulnerable population in the system, we can use this twin track approach, which mainstreaming, making sure that general health services are accessible and inclusive for everyone, and targeting, meaning that providing specific support and services that meet the unique needs of people with disabilities or other underserved population. So the goal is to have equal access to care and health. Thank you so much. Sorry for the exceeding time. I'm giving back to the moderator. Thank you.
Thank you, Lutfi. I think the time is exactly within 20 minutes. Okay. Next speaker is Dr. Jude de Villacong from University of Toronto, my colleague from Canada, on the Global South Artificial Intelligence for Pandemic and Epidemic Preparedness and Response Network. And we will hear about his experience on building network and fostering innovation in the developing countries. Dr. Jude, are you still online?
Yes, Dr. Adilas, and thank you so much, and thanks the organizers for the opportunity. I will be sharing our network, and I put our network here, which is the Global South Artificial Intelligence for Pandemic and Epidemic Preparedness and Response Network, and I emphasized on a model for decolonizing AI in the Global South for pandemic preparedness and response. Again, I'll be sharing the model, and it will align squarely when you look at the approach that we used. When I talk of a model to mimic, it will align squarely with what my colleague just presented before then, which is ensuring that everything is inclusive. If you are building solutions for communities, you should co-create with those communities and ensure that it's inclusive. And that's what you'll be seeing here. And then you will see how, when you do it that way, people will say it's difficult to co-create and do it very fast, but you'll be able to see some of the solutions that we have been able to build just within 1 year using the same approach. And again, before I move on to talk about this, I want to acknowledge the Canadian International Development Research Centre for the funding and the UK International Development, or FCDO, for their support. I want to share where I grew up. And the reason why I'm sharing this is, as I'm presenting this, think of the type of communities that we pay attention in. My colleague talked earlier on about including people with disabilities. In addition to including people with disabilities and looking at disaggregated data that take into account disabilities, gender, and also all forms of disabilities and intersections, we look at communities that are always left out of the formal system. So I was born in Cameroon, a very tiny community, a village, as you see, raised by a single mom. Again, the reason why I bring this is always thinking of different people, different dynamics within communities. If you are building proactive tools that will be serving communities, you think of the type of communities that you're building it with, or you build with those communities, taking into account the dynamics in the different communities. So raised by a single mom, 5 kids, and again, this is me here. Grow up very Catholic as usual. And this is my community, a very tiny village where if a school was to be built or the government were to offer a school, the community will have to build a school. We had 2 people with a car, and to go to the hospital would typically take you several hours. So people will either self-medicate when they are sick, or if somebody's about dying, then they knock at the door of somebody with a car. And most of the time, when you knock at that door, that person may have taken another person to the hospital. People will have to carry somebody on their back, where you get people dying out of malaria, out of dengue on people's back before they get to the hospital. Or because we had just one doctor, before you get to the hospital, you are told, move to the next city. Again, this is not the reality of somebody grew up in Cameroon in a bigger city, but this is the reality of some of the communities that some of us grew up in. And these are the type of communities that AI for PEP tried to serve. If you look at my community, it was a very tiny community, one hospital here in Jakiri, and the major hospital was here. And for you to get there, the route was horrible. People end up dying. In every country, be it here in Canada, you have these type of communities that are far from the central system. And the question that we asked when we try to form the network is, how do you build proactive tools? Because if you allow this type of communities for things to happen and you have to react, nobody will care about this type of communities. How do you build tools that are proactive so that we don't have to react? Because if they are proactive, then they get to serve this type of communities that if everybody were to be eliminated, if this community was to be eliminated, nobody will ever hear about it. And these communities exist. Once you build tools that address this type of communities, these tools will address every other community in the country. And this is where AI for PEP comes in. And this is where people like Dr. Adilas have been working squarely in Indonesia. And Adilas, thank you for the great work you've been doing. Thank you for your leadership to be able to ensure that they get data from such communities and make that data actionable for policies in the countries. Where, thanks to his work, he's building earlier warning systems such that you do not have diseases surprising such communities. It becomes very proactive. Everything is known ahead of time, and then things can be solved. And thank you for what we do. And this is what we do across all of the AI for PEP network. We are currently in 15 countries, span across the entire global south. But now we have moved to 21 countries, thanks to additional support from FCDO. We meet every bi-weekly. We share experience across countries where somebody is building something in Indonesia, and then somebody in Ghana sees that, oh, this can be adopted in Ghana. And then they work together to adopt that in Ghana and vice versa. At the same time, once we see that, again, the type of communities we work in, the people that are selected to be part of this network are those who pay attention to what my colleagues talk about, people with disability, the type of communities I just presented that are not here, and all intersectionality you could think of. Once we come together and discussing all these issues and people are seeing how we are addressing these issues, then we learn from each other and we're able to build tools that are inclusive. And that's our approach, by meeting every other week, sharing experience, and people learn from each other. The first thing that we do, we always talk about our foundation as we meet. It's always on health and well-being for all and gender equality, SDG 3 and SDG 5. This is a solid foundation with 3 pillars. I want to pay attention. Timely and reliable data for public health decision-making, ensuring that we strengthen the healthcare systems, and then including vulnerable communities. While we have these pillars, and then we have 4 thematic areas: creating tools, earlier detection, we detect disease before it happened, very proactive tools, earlier warning system that can warn the community, earlier response before things happen, and then mitigation and control of developing epidemics. Why not losing track of the fact that human health is not dissociated from animal and environmental health, the One Health concept, and using artificial intelligence as a catalyst. I want to emphasize of the word catalyst, entry point. With that, using artificial intelligence as a catalyst, including this community, there's a movie that I watched recently, and I could not go on without asking if you have watched this movie. I don't know how many of you have watched Atlas, but if I were in the hall right now, I'll be able to see. Unfortunately, I cannot see the hall to know how many people have watched Atlas. But Atlas is a movie acted by Jennifer Lopez, who was Atlas in the movie. Very skeptical of artificial intelligence. The mother created Helen, who led a revolution against humanity, at some point leading to catastrophic life and even kill Allah's mom, and wanted to destroy humanity because he felt that, well, given the instruction that he was creating, humanity was acting against their own interest and wanted to get rid of all humanity. Atlas was on a mission to destroy Haaland, which was the AI terrorist, but it was another AI, Smith, that helped to achieve that mission of getting rid of Haaland so that he doesn't destroy humanity. And one additional thing, Smith gave up his life in order to save humanity. So the question we ask ourselves as we try to build this AI solution is, are we building Haaland or Smith? If you're building for vulnerable communities, how do you ensure that they save those communities? The first thing we do before we move on, and this is what we started earlier on, was to come up with a framework. You want to ensure that you build Smith and not Haaland. In our framework, we first of all ensure that before we move to anything is the data. Data is very important. We want to ensure that the data that we are collecting is locally relevant and informed by communities that we're dealing with. We want to ensure that it's responsible and ethical for policies and regulations. And once this is achieved, we want to ensure that it's explainable to the entire society at large before we move on to collect the data, design the model, deploy them, observe the performance, monitor it, and continuously feedback the data. Again, with all of these, we ensure that responsible here means accountable, auditable, compliant, ethical, respectful, safe, and secure. Explainable means equitable, fair, interpretable, reliable, reproducible, transparent, trustworthy, unbiased. And local means trying to ensure it's autonomous, caring, connecting, decolonized, human and community-centered, inclusive, intentional, intersectional, just, practical, protecting, process-based, and sustainable. And these, we try to contextualize it to every local community because this means different thing from one community to another. We contextualize to the local law before we move on. I just want to just use the remaining time just to point out within 1 year the type of solutions we have created. In Ethiopia, it's difficult. You still have a polio outbreak. It's difficult to, before it was very difficult to distinguish acute flaccid paralysis from normal paralysis. But we were able to build an AI tool and integrate that in an app, give it to community workers and government. Now, once you have somebody, if you have any paralysis at home, you just take a picture, send it to the system. The system is able now to detect with a certain percentage whether there is suspicion that this may be acute flaccid paralysis. And once that is determined, because it's connected to the government immediately, there's an alert that alert the government, and then an officer is sent to your home. And this is advertised in churches. People are using those type of communities that are always neglected, where you don't have health centers even. But now with their phones, they just take the picture. Somebody will know without them even alerting the person. In South Africa, we have been able to look at air quality and build a tool that's able to monitor the air quality indoor and outdoor and project it, because we built an AI algorithm to be able to project the quality of the air. In Brazil, we have been able to build a chatbot called Dominic, which you can currently find out in WhatsApp, as well as Telegram, that's able to get any news and determine to what extent that news is true. Again, this is built by training AI models to serve communities that are often misled by misinformation. In Ghana, we have built a tool that's able to monitor different vectors and forecast them. Again, we monitor the vectors, monitor the temperature, just get the sounds of the mosquitoes or the different vectors, and then take the location, and it's able now to build it on our data portal. And then we have AI models that are able to focus that going forward. And this is helping a lot of communities. As you know, a lot of vectors are coming. Not only that, we're equally looking at unconventional data. In Tunisia, we built a data portal that rely on wastewater. And tracking different diseases from the wastewater and making sure that the data is available to the communities and policymakers to use and the public for research. Again, in Peru, we have a breathalyzer that's able to determine different respiratory disease, and that is currently being used by community workers, used by the government in different hospitals and in type of communities that we work in, where people may not know the difference and self-medicate. They're now using this breathalyzer across the community. And again, my colleague here, Professor De Castro, will be talking about the amazing work that they are doing in the Philippines. I will just mention about being able to use the telehealth data that has created. He'll talk more about this, be able to diagnose neurocognitive condition from there, and working with the type of communities that we mentioned here that are often neglected. And thank you for the great work that you're doing, Professor De Castro. So far, we have created a huge impact. We get a lot of people accessing our solutions and articles. More than 60 million people, we track all of these. We have a lot of people that have received, our team members have received a lot of research awards. We have more than 216 published news articles, put in international media coverage. And we have at the moment, more than 150 peer-reviewed articles that we have published. We have books that people are accessing, more than 1,100 people are accessing the books that we have created on democratizing artificial intelligence. And we have impacted more than 60 million people as we track the impact of our work. In addition to that, we are not leaving it, we are building capacity. Again, I want to just seize this opportunity to congratulate our younger ones from the Philippines, from Indonesia, for the competition that we just had. They came in first. In that competition. That shows the type of capacity that Adilas is building at the center, because these are students that he trained and they came to the competition. This was a competition that has students from 21 countries, several students from several universities, top universities around the world. And these students were able to win in their innovation. So I want to congratulate them. And again, set the example of what Adilas have been building. And this is what all AI for PIs are building across the various countries. We would like to call on you to follow us on LinkedIn, or just check our website for the different projects that are ongoing in different countries, or how to join us, because we are looking at building a network of people that care about this type of communities. Thank you so much, and merci beaucoup à tous.
Thank you, Dr. Jude. Interesting presentation. I think you won't join us with the question and answer session because it's already late there. Okay. Yeah. So it's amazing that we can see that innovation, especially in AI, doesn't always coming from the Western countries, but also from the developing countries such as Africa and also in Asia. So we can learn more from them. And it's shocking that some of the innovation, it's not yet implemented in Indonesia yet. So we can learn from them. Okay, we going next to our next presentation. It's coming from Dr. Romulo De Castro. Usually I call him Dr. Jong. He is from Center for Informatics, University of San Agustin, the Philippines. He will talk about digital health outreach for the underserved communities. Dr. Jong, time is yours for 20 minutes.
Many thanks, Professor Aldilas. I apologize, maybe my voice is a little bit too low right now. I'm sort of sick, but since it's only like online, I can still give my talk to you. I really appreciate the talk that preceded mine, and with Lutfi and Jude, who gave some very interesting takes. Let me just mention that, you know, in Jude's example where he gave, you know, travel time to hospitals that are many, many hours because there's one central hospital that the patients go to. In the Philippines, and I suspect in Indonesia, it would be the same, except you travel between islands. So I was reminded by, you know, a case where there was a pregnant woman in an island in the Philippines that needed to give birth. It was a complicated birth, and they had to travel to the hospital, which is in another island. It takes 3 hours, you know, to go to the hospital one way, and along the way, the woman died. And there are many cases like this in the Philippines, where, you know, populations living in very remote areas are are denied or don't have access to healthcare that it actually exists. But it takes a lot of effort in order for them to access healthcare. All right. So let me share my screen and then just give you, uh, you know, uh, a story on the things that we do in the Philippines. I wonder if you can see this. Let me put it on, okay, in this mode. So I'll be talking about our work in the Philippines, which is Atipan. It's called Atipan. But, the title was provided to me and it describes exactly what we do. So thank you for the title, Digital Health Outreach for Underserved Communities. So I'm Romulo de Castro. Professor Aldi calls me Jong. So that's Jude. And I lead, the Center for Informatics in the University of San Agustin in Iloilo City in the Philippines. Most of what I'll be talking about, you can get from this publication that we already, brought out back in early 2024 when when we finished the first part of this project. And then fortunately, we were noticed by the Global South AI for PEP pandemic and continued our funding. And therefore, we continue to do this work, in indigenous communities, rural low-income communities. All right. So let me just say that Atipan has been a digital health implementation success. So, and these are the metrics. It took 6 months for us to prepare the communities, infrastructures, patient navigators, et cetera, et cetera. And the uptake of telehealth, in these underserved communities is extremely high compared to developed countries where the uptake is, only 22%. In our communities, at least in the first 2 years, the uptake was getting to 70 to 80%. The reason for that, of course, is that because they don't have a choice. It's either telehealth or there was nothing. They would travel, long hours to go to the healthcare facility. The telehealth data, which is the consequence of telehealth consultations, is collected in an electronic medical record. It's not just a byproduct of implementation, but becomes a healthcare resource for the communities and for our own healthcare system in the Philippines. And Atipan is digitally enabled, and pretty much this is the only way these days to be able to reach really, really remote communities on demand. Oops. All right. You don't have to trust me on that, but you can trust what the communities are saying about our program. This is originally a video, and if you screenshot this and then go to the site, it will play for you. And what it is, our community said that they no longer have to spend for transportation to see a doctor. So that's very heartwarming for us because sometimes, when they started using telehealth, it was the first time they ever saw a doctor. So to us, that was a very nice story. And when we finally did, get feedback from the communities, this is what they said. Again, there's a video here. I didn't put the URL, but essentially what they said was, and this is in Filipino, telehealth saves effort, time, and money. Their money, which is very little to begin with. And then communities want, increased coverage. They want telehealth to help more patients and for the program to last longer. And probably because these types of programs, sometimes we start them, but they're not sustained, or the government doesn't have, a program to sustain it, which is so strange, particularly if it's already been demonstrated that the communities want it. So this is what we're working for. Right now, we're working, we have international grant funding. But you know what happened recently when USAID was just stopped, all of the funding disappeared. And, if we don't get our governments to actually fund these efforts that are leading the way in providing healthcare to the margins, then, we'll go the route of, the other, programs that are beautiful programs. However, they were dependent on international funding. And when that disappears through the whim of politics, then okay, we would become at a loss. All right. This is our program. Originally, there were only 10 communities, but in fact, we have actually expanded to 5 more communities. Actually, just in the green box, this is 2 communities. So This is because of the funding provided to us by IDRC. So thank you for that with Dr. Jude. uh, and the program also won a lot of awards in innovative implementation, communications, and maximizing gender benefits. Becoming a laureate of the Global South eHealth Observatory, um, receiving local awards for some of the work that's been done by our personnel, and also getting other agencies to fund wider scale conversations on indigenous health. And lastly, Mental Health Commission of Canada said, hey, this is a great idea. So they highlighted, our work in their 8 great ideas changing lives worldwide. So now, Atipan is not just originally it was in 2021 to 2023 was funded by the Asian Development Bank. Now it has expanded and are now being funded by the Global South AI for PEP Network to the IDRC and the FCDO. And we have a host of smaller funding from ODES, Fundación Pierre Fabre, Columbia University, and our own local university foundation. So our aim originally was just telehealth, but now that we've become a part of the Global South AI for PEP network, our focus is pandemic and epidemic preparedness, as elaborated on by Professor Dr. Jude, with the final end of improving health outcomes using modeling, a lot of mathematical modeling, including cost modeling and economic modeling, that would eventually be injected to policies and eventually a learning healthcare system. So now I'll get into the nitty-gritty. A participatory approach is vital. This is what we started with. Without this participatory approach, there is nothing. You cannot even go into the communities and perform telehealth. It has to be accepted. There has to be social preparation, which is community-centered, and leadership building. Leadership building in that what happens is eventually, or what we hope to happen is that eventually the communities themselves will take up the solution and advocate for their own health care. So this is all done ahead of time. The solution is integrative, creating space for disempowered communities and to promote people's well-being at the foremost. So not even health, but actually well-being, including mental health. And there are many things that we learned and we unlearned while we were implementing this solution. And we learned mostly from the communities themselves. They told us how to implement properly. Community empowerment results in healthcare transformation. And how are these communities being empowered through our program? Through the use or the designation of what you call healthcare coordinators from within the community. These are our patient navigators. They're already part of the community, and they're the ones that are actually driving the implementation as well as the sustenance, the sustaining of this program. We have provided mobile devices and accessories. So this is the technology provision, internet, because in these communities, there's not much technology going around, and even much less internet. But somehow it still works because we did all sorts of preparations, and I'll show you that in a minute. We've trained, the folks in the community that are facilitating telehealth, and we provided basic supplies. Believe it or not, in these communities, even basic supplies are needed because of poverty and because there's no supply line, from the government to these communities. The government sometimes cannot reach these communities, and therefore they depend on organizations like ours to bring some of the supplies to these communities. Our implementation approach was deliberate and it was values driven. So primarily our value of fairness, meaning prioritization of the least, the people who have the least access to healthcare. That's only fair because everybody at the center already has access. However, those in the peripheries don't have access. So to be fair, we have to prioritize these communities that are outside the center, as Jude said. It has to be context sensitive. There has to be a need. If there's no need, there's no point in going. And willingness from the communities, provision of infrastructure and capacity. And we have to engage the communities. These are the social preparations that I mentioned earlier, and an eye on the utilization of the data that will be generated from doing digital healthcare in these communities. So from the very beginning, we knew that we will be coming into data, and the data we've already thought would be used for operations, disease profiling, and also recommendations for local health policy, particularly for our own implementation of universal healthcare. We subscribe to the values of health data governance, and this is derived from Transform Health, which is advancing these values in the United Nations. The main values are to protect people, prioritize equity, and promote health value. And there are sub-values, within these priority values. This is the architecture of our technology and the interactions with the people. So technically, the telehealth is is configured with 3 participants. First, the doctor on one side, the patient on the other, and a facilitator called the healthcare coordinator. These are the patient navigators. All of the data go into our electronic medical record, and many of the communications happen through mobile phone messaging. I mentioned healthcare coordinators or patient navigators at the center, or the communication between the patient and the doctors. Sometimes they do translation. Sometimes they even help with medication, how to take the medicines, and just in the end, really holding the hand of the patients who have never seen healthcare before. So these healthcare coordinators are within the communities. They are knowledgeable, and they have familiarity with technology, and we provided them with internet and the mobile devices. We have 35 of them, and there are collaborators in the communities, and we've trained them adequately in many things, in basic medical procedures, such as just taking temperature or blood pressure, in use of the informatics equipment, and also in the distribution of health supplies. We also prepared the communities for internet, because telehealth cannot happen without the baseline internet and devices. So this is one of the things that we did really deliberately, because we wanted to make sure that our communities that are very remote actually had internet and electricity. So we studied all of the potential providers of electricity in our communities, and guided them to which ones to use primarily, and maybe even a secondary provider in case it's raining and the primary signal disappears. And that happens often. So we had to make sure that there were alternatives. And this is just mentioning that what we do is actually primary health. But a really well-prepared primary healthcare system is also the foundation of universal healthcare, and that universal healthcare eventually creates a more resilient healthcare system when it comes to pandemic and epidemics. And now I'll show you a little bit of Datipan data before and I'll be very quick. And this is as of August 2024. I still need to redo the do the reanalysis of the data, because we have a higher level now of patient telehealth consultation. So first we do the registration, and we look at the registration, the number of patients that are being registered, and then we look at the number of encounters that are being performed. You can see that the registration or the encounters actually mirror the registration. So what this means is that if you just register the patient into the system, eventually they will come and and visit for telehealth consultations. So first, register the patients, and then telehealth consultations follow. Okay, for all of our communities, this is our data for age and sex distribution. So you can see that there are more women and girls that are using telehealth than men and boys, and that there are many children or adolescents that are patients of our telehealth. So this is for everyone. This is a top 15 diagnoses that show up. You can see many are respiratory tract infections. But when it comes to tropical medicine, look, Number 12 is actually pulmonary TB. And this is actually not surprising, but still shocking to us because when we looked at the initial numbers, the extent of TB in indigenous, well, in our communities is 3 times the national average. It makes sense because in our communities, there's no healthcare other than us, and we're telehealth. So we're not specialty health. So this is where, pandemics or epidemics root because and propagate because where there's no healthcare system, infectious diseases just run rampant. So this is, what happens. So we can see TB as one of the top 15 diagnoses in our, and you can see malnutrition is there as well. Malnutrition should have been solved by now in an agricultural society like ours, but it's still there. And it is odd that malnutrition occurs in our farming communities even. So this is the data for the indigenous communities that just mirrors our all of the communities. Again, look, malnutrition, pulmonary TB is still there. UTI, this is a urinary tract infection, may be indicative of the extent of sanitation in these remote communities. In the farming communities, so a little different, more women and girls using, maybe because the men and the boys are, in the farm and working, but also a difference in the distribution of the higher age groups in using telehealth. So yeah, so again, these are the top 15 diagnoses. So interestingly, a lot of not only can we look at the diagnosis, but also the prescriptions that are being used. And some of the prescription data that we have been used as guides, to plan for resources for the local healthcare system. All right. So the rest, so I'm about to end. The rest of the innovations that we are doing in Atipan, our telehealth program, is a caravan of telehealth for the further communities where there's no electricity and there's absolutely no signal. And we use satellite internet for that. We've done this once and we plan to do it again. We plan to do it more periodically, to be honest, as we get partners that will help us with with the caravan. We're also bringing healthcare services to the communities where there's no labs or imaging. We're trying to bring them. We've also done it once. And now we know the program, how to move forward with these caravans to the further communities. We're developing the health map for continuity of care. This is what happens to the patients beyond telehealth because telehealth is primary health. So secondary and tertiary health, of course, they still need help for complex cases and they need patient navigation. And also lastly, to ensure that that we are hitting the gender SDG, as Dr. Jude said, we have been conducting a gender audit on our program. So this is our health map app, and you can see that there's actually a lot of facilities in the region that we are. Okay, here's the problem though. These are the facilities reported by our government, and unfortunately, our government lies. These are all not true. Well, not all. There's a lot of these that are not true. And we are in the process of validating which of these facilities are real and which are just lists. And this is our gender audit methodology. This is the last slide, by the way. No, maybe second to the last slide. And with a very, very innovative methodology in trying to find out if women in the communities actually help the technology that we have rolled out. And lastly, here it is. So I came across this from another group, and they've elaborated to us the inverse equity hypothesis. And what this means is, there really is a sad distribution of healthcare resources across the population. The ones with privilege usually hog all the resources to the detriment of those who are in the margins. So what this actually tells us is that when we develop health technologies, we should develop them for the segment of societies that are already inequitable. So, and making sure, so I'm almost done, and making sure that that technology is prioritized. So you do not roll out the health technology that will equalize healthcare to everyone immediately. Because if you do that, those who already have privilege will further widen the equity gap and hug those resources for themselves. So basically, what this says, and the priorities in AI for PEP in our network is real and it's true. We prioritize, health technology for the populations that are in the margins, underserved, remote, and not yet reached by public healthcare resources. So with that, thank you so much, to IDRC and FCTO for our funding, the rest of our funding agencies, and our collaborators. Thank you so much.
Yeah. Thank you, Dr. Jong, for your talk. I hope you can still join us until question and answer session.
All right, I'll do that.
Yeah, thank you. Okay, the last speaker for our for this session is from Indonesia. He's coming with us in offline session. Pak Anis Fuad from Universitas Gadjah Mada. You can join me with. Yeah. He's a lecturer in the Department of Biostatistics, Epidemiology, and Population Health in Faculty of Medicine, Public Health, and Nursing in Universitas Gadjah Mada, and also researcher in the Center for Tropical Medicine, and also Center for Health Policy and Management in Universitas Gadjah Mada. He will talk about the potential and strategies of TB information system in bridging health inequity in Indonesia. Pak Anis, time is yours for 20 minutes.
Thank you. Thank you, Mas Aldi. Good morning, all participants, and also good evening to Dr. Romulo and Jude, and very good morning to Mbak Lutfi. Thank you very much for the moderators and all the speakers. And I think all the speakers already presented some issues related to the inequity that helped me easier to present my topic. And I promise to all participants, we are coming to the time of lunch, and I promise you to make you hungrier. Hungrier literally say that food always tastes better if you are hungry. And hopefully you are hungry for the knowledge and insight after this presentation. Hopefully. Okay, I will present about these 4 topics. I think on the first aspect on the health inequity, thank you very much for Mbak Anissa, Romulo, and Jude that presented several issues related to, for example, the accessibility, the different characteristic of the people who accessing health services. And on this kind of context, I think the main question is how our health system provide a just and aware system to ensure that all people with a different characteristic could have or receive a just and fair access for the TB screening, treatment, and also monitoring, so that they can secure and also later on cure from the TB. I think that will be among the most important topic that I will discuss, mostly about the TB or Sistem Informasi TB or SITB. And with regard to this context, I just quote one of, I think, important paper that measure the inequity of TB even in high developed countries in Europe. From the longitudinal data, it say that people with socio-economic low status mostly have more affected in terms of the morbidity and mortality. You can see from the data, and also you can look into the paper later, that people with lower socioeconomic status will have higher mortality of TB. And this paper could also be useful for us to inspire. Is there any studies or any other characteristic that need to be drill more detail. For example, in terms of the geographic disparities, and then digital divide, people with more easier to access telemedicine probably better on the TB screening and consultation rather compared to other area. And also whether this kind of situation also different with related to the gender or the vulnerable liberty status. And I think the most important is how we can use SITB as an instrument to improve the health status of the population. When we talk about SITB, I think it is among the important instrument for the TB surveillance in Indonesia. It is not only about a database, it is a tool that integrates TB services from the screening and then monitoring of the treatment, and also to ensure that health services also tracking the patient and also the communities, and also to monitor the adherence of taking the drug. SITB actually in Indonesia started earlier when it was started from the manual model, and later on it will come into the Excel-based format, and until now we can come into the situation where SITB accessible through a web-based or through the system informasi TB. They have also other TB-related information system. For example, other teams supported by, unfortunately, USID that already turned down. The SITK, the system informasi on the community, they monitor as well about the support of the patient. So I think there are a lot of ecosystem related to the SITB that I think it is also important for us to understand, to learn more. And I do not know, I think with the lot of data already collected, it is also important for us to learn about how the potential of SITB to improve the status of the community. In SITB, all members, like what I mentioned before, health facilities, including primary care and also the hospital, could be registered into SITB and then register from the presumptive cases of TB and until confirm of TB, and also to monitor whether the patient already received drugs and also the process of referral. So we can see the function in the SITB, not only to enter the patient data, but also for the district, they could also possible to have the function on monitoring and have also access to the aggregated data and also individual data. And also currently they already integrate between the patient data logistic and also with the case management system. And I think it is also good that right now there are more and more research using SITB. And also I think our students in FETB also have several publications related to the SITB. If you see from the SITB, one aspect that you can learn more is especially related to the characteristic of the patient. They collected data related to the national identity or NIK, and also BPJS Kesehatan status. From these two data, we can actually integrate this data with the social economic status. We can have data more detailed related to, for example, the gender, the address, the rural urban level. And if we also use the BPJS Kesehatan data, actually we can have a proxy on the socioeconomic status with the situation and the condition. Health facilities also validate the BPJS data. You remember, I think last month data related to someone with a very rich, but the status of BPJS Kesehatan is in the third class. I think this is also among the important question for us, given that Indonesia right now already achieved universal health coverage, because of this is the mandate from the national government. All the province register all the population into the BPJS Kesehatan, uh, but if they do not have the function for validating, I think that will be another issue on whether we can use this data from the BPJS Kesehatan also accurate for inequity research. One of the study that I would like to refer is any one of you published this paper or a friend of you are listed here. This is a student supervised by Mas Bayu, presented the factor associated related to the successful of the TB treatment based on the SITB only in Bantul district data. You can use SITB using TB03, and then from the data, it measure that people with female, and then in the productive age, and also receive a contact investigation, has a greater successful rate of the TB treatment. So we can see, for example, in this data, for example, the issue of gender, the issue of age, and also the role of people receiving access for the contact investigation. I'm also worried. Probably those receive contact investigation are people in the urban area or people in puskesmas where they have staff to conduct epidemiological contact investigation. So this is, I think, one of the issue on health inequities. If we could also use this data and also understand, we could improve and also get a better understanding about how to have more and more research on health equity in Indonesian context. So importantly, Ministry of Health already provided SITB data as aggregate format in Satu Sehat dashboard. You can access the detail of this aggregated data in Satu Sehat, but for those who would like to analyze more in the individual level, it is better for you to collaborate with the district or with the province. I think if you propose them with a research proposal, they will be very happy to willingly collaborate with you to analyze on the individual data. But at least at the national level, we can analyze, for example, the issue of inequity from the spatial perspective, from comparison between province or district, because in Satu Sehat, we can compare by district or by province. I think the last part of my presentation is about the potential and strategies. One of the important paper that I would like to recite is digital health equity framework, which combine the social determinant and health and also the digital determinant of health. In the social determinant of health, it says that the condition in which environment, people living, born, work, play, and gender, age could influence the quality of life. But also right now, where in the condition right now, people have more accessibility to the digital environment. There is also digital determinant of health, in which the condition of digital environment could also associate with the status of the people, of the health people. So I think in this kind of context, I think we need also to think about how to apply these concepts and also to implement on how improving the TB patient and using this SITP. So to understand more and to implement, I think it is also important for you, if you do not have a chance to access this useful information from WHO, Digital Health Intervention Services or classification, that mention several type of classification, including the digital intervention, in which I think several aspects, including, for example, the telehealth, the monitoring, reminder, accessing to data, literacy, etc. It is already mentioned in this digital intervention classification. So to address health inequity using SITB, using the framework, what I propose is at least there are 4 aspects to bridge the health inequity. The first one is on the individual level. The second one in the interpersonal level, in which healthcare providers support the TB patient. The third one in the community, including the family or the environment. And the last one also in the society or in the national level. In each aspect, I think digital intervention could also be supported by the SIDB. For example, SIDB right now, if you come into Satu Sehat, in Satu Sehat, there is a function, for example, on the cek kesehatan gratis. I think this tool will be coming soon, especially for the screening, including the screening TB. And also the tool, for example, on the monitoring of drug. I think if we come into detail about this drug monitoring, we can see that in the individual level, SITB, if it is integrated with the mobile application, could be useful for the individual level. For the interpersonal level, I think it is also important to support the health workers on using SIDB and also monitoring the patient as well, using mobile application as well. We have actually a previous study, for example, on using a mobile app application to monitor patient with the TB MDR. And if we could also integrate this, we have Satu Sehat, we have mobile JKN with other application. I think it is also good to discuss about interoperability between all application. In English, if there is one app, we call this app. If many apps. But in bahasa Indonesia, if there are many apps, what we call this? Apps. Apps artinya banyak aplikasi. So we need to discuss about how to discuss about interoperability between all application, especially for individual level. So I think the call for action, I think it is also difficult. In the time where efficiency is the #1 word, we need to improve still the infrastructures, including the digital public infrastructures. Many still, we heard that several puskesmas or health facilities could not access with the digital environment. I think we need to spend some money from the government to support the infrastructures. And I think the call for actions for the SITB, I put the 4 aspects. The first one is enhancing research and data utilization for using SITB. Like the case I mentioned regarding the data from the Bantul, for example, we have 400 districts in Indonesia. If you are working one with several districts, we can have more understanding about the status or situation of inequity in related to TB in Indonesia. Secondly, we need to strengthen the digital infrastructures in Indonesia. And the third one is integration between SITB, Satu Sehat, Mobile JKN, because if we could combine those things, I think it will be making the health workers' life easier. They do not need to enter many applications in their work. And also developing the apps, integrated app, and also capacity building for the health workers and community health workers. I think that's all my call for action for the discussion related to the potential and strategies for using SITB to bridge the digital health inequities in Indonesia. And I'm closing by saying that SITB not just a database, not just a tool, not just an application, but if we consider to use SITB as one of the solution, there are more room for improving our people, especially those with the TB situation, and also the health status by all population in the district and all national level. Thank you very much, and then I return back the time to Mas Aldi.
Okay. Thank you, Pak Anies, for our last speaker. Yeah, I think it's almost lunchtime, but yeah, we have still another 20 minutes for question and answer section. We open with the three questions. Ya, Mbak, yang with black veil. And yeah, first one.
Yeah, thank you for all the presentations. My question is for Mbak Lutfi. So my name is Abelia. I'm from the Federation of Red Cross. So if we observe the recent political situation, there have been some changes regarding foreign support, particularly from the US, to suspend all assistance in the field of DEIA or diversity, equity, inclusion, and accessibility, including for disabilities. In your opinion, could this decision lead to a wider gap in health inequity, and how can we address this issue? Thank you.
Okay, next question. With long hair.
Check. Thank you for the opportunity. My name is Yusli. I'm from FATP UGM. I have a question for our lecturer, Bapak Anis. So this is really interesting that the idea of integrating the apps we have. And I have one question that it's really make me questioning. Why is it so hard for the government to integrate all apps the government had? For the example, in the Bantu only, for the disease record, we have two apps, and it's not easy for the health worker to input the data. And this is really like a basic logic that if we have one integrated data, so it will make our health worker easier to input the data without any bias or any duplicate of the data. So I'm really wondering why the government is so hard to make these apps integrated. Thank you.
Okay, this last question. With glasses.
So good afternoon. My name is Raffi Morivaldo from the Faculty of Medicine, Universitas Pajajaran, and I would like to ask Mr. Anis and Mrs. Lutfi, and it may touch the other presenter material also. So firstly, I want to say I've experienced in a somewhat remote village, and unfortunately, with the advancement in TB monitoring, there is yet the problem of stigma and the denial in these villages, which proved to be a difficulty for the staff to monitor this TB. One of the Puskesmas staff even shared a story to me of a villager with an active TB that ran away to other villages and unfortunately died just because he didn't want to be bothered by the staffs. Other than the informatic advancement, what social strategies may be, from your opinion, or are they implemented in other countries that can be implemented in our remote or villages or other villages that share those inequality that can help in addressing those problems and enhance the monitoring, would say, with the SITB in those areas? Thank you.
Okay, thank you. Yeah, I think the first question is for our speakers regarding with the suspending of the funding from US especially. Maybe what's your comment on how usually USAID has many projects on research and inequality, and how you Mbak Lutfi, Dr. Jong, Pak Anis, yeah, how to manage that problem. Maybe Mbak Lutfi first.
Thank you for the question. So probably I will focus my answer focusing on inclusivity of people with disability, because that's my area. So I presented the framework for inclusive health system. How does it look like for health system to address the needs of people with disability? So in that framework, in the system level, there are several intervention, or that the health system needs to be adapted. For example, like in the governance, we have to have law or policy. In Indonesia, we have that the law on the rights of people with disability, number 8, 2016. So that's our base for the intervention in the future. And there has to be leadership in the Ministry of Health. Now we have the task force for disability. We have the subunit focusing on disability in the Ministry of Health. So that's our what is it, like we call capital, or to address the needs of people with disability and to build more inclusive health systems in Indonesia. And now we have already the National Commission of People with Disability, which the one of the tasks is to monitor and to evaluate the fulfillment of the needs of people with disability, including health. So we have we have already the system, the part of the system in place that needs to be incorporated. And currently, the Ministry of Health actually is developing the roadmap for inclusive health service and health system for the next 5 years. So actually, we have all in place at the system level, but what we don't have, what we still need to monitor and evaluate is the implementation in the grassroots level. So we have all the system, but then that's actually make us like to have priority in that area. So if the funding is stopped, and the government need to have priority in that area, and we have already the governance, the law, the policy, and what we have now, probably we have to have the priority and also the intervention and implementation at the grassroots level, at the system and service delivery level. I think that's my view.
Thank you,
Thank you.
Mbak Lutfi. Maybe Dr. Jong, you have on text.
Yeah, thanks. That's a very, like an acute problem because, that happened, and all of my friends who are working in USAID now have no jobs, particularly those who are in Southeast Asia. Let me give you maybe a quick picture. In the Philippines, there's a lot of funding for health that is provided by USAID. In fact, I know of a TB program that was funded to the tune of almost like $100 million US. But for that, I think it was awarded to to an American contractor. But there is funding that is counterparted by the Philippine government. So what that means is that there is actually funding that is local. There's funding that is local that actually can be used for TB. So for a while, I was actually afraid that maybe the TB medicines will stop coming and they will be, stop being distributed. But again, because there was counterpart funding from the Philippine government, in partnership with USAID. When you pull out the USAID money, that means there's still money from the government that addresses TB. So what we need to do is to find ways to make that money, maybe cover, TB in our country more intelligently. So that we don't need to be dependent on foreign aid for our healthcare. And, I mean, of course, I can say that about TB in the Philippines, but, the other programs like HIV, for example, malaria, and many other, diseases and maternal health, reproductive, health. I don't know what the picture is. So we do need to build our own resilient systems because, we can't be dependent on, on foreign health aid all the time. And now we know that it's going to be, stinging for us, to adjust, to this development just because there has been a change of leadership in, the aid giving country. So it can happen with the US, it can happen with other, agencies that are supporting us now, could be Europe next time, or maybe Canada even next time. So we just have to be maybe supporting our own at some point in time.
Thank you, Dr. Jude. Maybe Pak Anies have comment.
Yeah, I think previously many discussion about the double burden of epidemiologic situation in Indonesia. Right now we discuss about a double burden of funding from external and then from the national. We also have weight efficiency, something like this. So I think the important for us is, I think for every district, every province and also national to discuss which component, especially for the essential services that possibly stop, and also the support from the support for the communities. For example, several NGOs also stop in the field. I think all the leaders in every level need to discuss and then to propose strategies. I think many experts already discussed about this issue. I don't have any experience on that. I think that's
Okay, thank you, Pak Anies. Maybe directly for the second question on the integration of the system in the TB care.
yeah. I think in many cases, and I think in almost cases, information system was developed after there are needs to have this information system. So I mean, in Indonesia, in the Ministry of Health, there are many health programs from CDC, non-communicable disease, and other. And each program need to have a strong monitoring and surveillance system. And with the coming of the technology, so every program need to have this information system. And it is also because of every program have their own budget. So every program finally have a proposed budget for information system and then find the vendors from national, including province and district. And finally, there are many vendors supported this government. I think this is the root cause of why there are many application. And I think when we discuss there are many application, it is actually not truly wrong because application could also be integrated one to another. And it is a time that the Ministry of Health already published the standard for integration. But the problem is it needs time to learn about the standard. So for example, we learn about NIK, for example, National ID. Right now, National ID becoming the standard for all system for identifying individuals. Currently, we have also the new standard for transaction, for example, CRIS. So it becoming right now many system using this kind of standard. So I think it is a time that when all standard, including terminologies, classification, method of communication already in place, and all people learn, so the data exchange could be conducted even though there are many different applications. But there is still possibly a case when a system should also be, for example, closed because of the maturity level is different and also some problem related to the architecture. So I think Ministry of Health currently with the DTO, but I do not know also the status of DTO right now. They already set up this blueprint and hopefully we can have a more and more integrated system in our health.
Thank you, Pak Anies, on takes on the integration. I think it's the last question on the stigma on TB that might be widening the inequality of TB care in Indonesia. Maybe you have comments on this, Mbak Lutfi, first.
Stigma on TB. Actually, I have now I'm not working on TB, but I can have I can share my lesson learned from the the similar issues of stigma on people with disability. So now the Missing Billion, I'm now fellow in the Missing Billion initiative, have intervention for health workers training. It's massive one, but it is conducted in around sub-Saharan Africa, not yet in Asia. So what we are doing is to have health workers training to make the health workers more knowledgeable on disability. But I'm not sure about tuberculosis. But I think the health workers in the grassroots level, probably they have already having understanding on TB care and also the stigma on TB, but I'm not sure I can share about disability. So we have training health worker, because disability is something that the health workers still not really aware of. So we have training. First, they have training on what is disability and how to facilitate people with disability when they come to the health care facilities, and also to have the interaction with people with disability. But probably the lesson learned is that we can assess first in the very grassroots level whether the healthcare workers still really not aware about the tuberculosis and also the existing stigma around tuberculosis. Probably that's the problem in place, that healthcare workers still not really understand about the stigma, tuberculosis, and what happened in the society with tuberculosis. And probably if we know the problem causing the stigma among healthcare workers, we can build like some intervention. I think that's takeaways from our intervention around disability that can be learned for tuberculosis.
Thank you, Mbak Lutfi. Maybe Dr. Jong, maybe you have experience in
Yeah, I
there
do.
is stigma. Yeah.
Actually, we do. I mentioned that we encounter TB in our telehealth program. The same problems. Let me just make a quick comment on interoperability. We have the same problems in the Philippines on interoperability, and it's actually the problem of a health information exchange that I think the person was referring to. It can be done, so that's for sure. However, it's not trivial. So there has to be some agreement among the participants to participate in a health information exchange. And if you cannot get them to agree, then there will be no health information exchange. So I mean that applies, both to government entities as well as to private entities. So that's my comment on interoperability. Regarding TB, so you can imagine our indigenous people in the Philippines, they already encounter prejudice from utilizing the healthcare system, meaning they do not want to use the healthcare system because when they do, they encounter prejudice. They are called dirty, they are called diseased, and all of that. So telehealth actually is a great solution because when they do telehealth, they don't encounter that at all. So this is one of the nice experiences that that telehealth brings to remote communities, particularly indigenous communities who are already discriminated against by our own healthcare system. So for TB, in fact, our TB patients did not want to use the healthcare system that is in place for TB in the Philippines. But because they first utilized telehealth and became very comfortable with telehealth because they didn't experience discrimination to begin with, then they were a lot easier to convince to utilize the healthcare system that exists for TB. And so that was a good experience. So I guess maybe a lot of the things that we need to do is to dismantle discrimination and prejudice against against users of the healthcare system, so that if they have healthcare issues, they will actually use the healthcare system.
Thank you, Dr. Jong. Maybe last, Pak Anies, have any comments on stigma on TB?
Yeah, I think the big picture has been mentioned by Dr. Rumo related to the opportunities of telehealth to reduce the risk of stigma. I have several experience when visiting several health facilities when they reported several patients missing, and then after a certain period, diagnosis, treatment, and then miss. But then these patients were found in other district. Because of the SITB, when patient enter into the STB with the NIK, it was found that previously this patient has been treated before in other health facilities. So I think the issue of stigma probably part of the study to learn whether patient moving from one to another also previously has experience on stigma or not. And I think SITB could also have opportunities for that, even though we know that several issues related to migration, population dynamic could also there. But I think SITB could also be useful when we have the NIK already in place in SITB.
Okay, thank you, Pak Anies. Maybe because of the time constraints, I think we can end the discussion session in this. So let me summarize up for this session. So the first one is, I think we know that in the context that people with disabilities and the other disabilities that have gap, there's got a large gap in life expectancy and disability prone to have infected with the infectious disease, especially tuberculosis, for example. And then they have higher level needs of the healthcare that we can, there's so many research opportunity in their section. And then we learned from Dr. Jong that participatory approval for social innovation is important. So anything that we build solution innovation that we think might help the community might not be accepted before we have social interaction with them. And then lastly, I think we can conclude that digital health has a big opportunity in bridging inequality and strengthening by strengthening integration and interoperability with between digital health solution. I think we can conclude this session for symposium 4. Applause for us. And back to MC. Thank you.
Thank you so much, Pak Aldilas, for your time and bring us for the Symposium 4 that discusses about bridging the equity gap and ensuring access to innovation in tropical disease prevention and treatment for all. Once again, give applause for our speakers and moderator, everyone.
I think everyone is excited for the next lunch break. But before that, we're going to give some information. We sent you the newest program book of the second Gajah Mada ITCM 2025. If you haven't accessed the new program, you can access by scanning the QR code on the screen over there. After lunch, we will proceed with the oral presentation sessions, which will take place in 6 different rooms.
There will be several rooms that can be assigned as the oral presentation sessions. Here at the main auditorium is pointed as best practice, and then at discussion room 1 at Grawianta for tuberculosis and related studies, at discussion room 2 for vaccine and drugs, at discussion room 3 for vector-borne diseases, at discussion room 4 is for diagnostic, clinical management, and digital health. And last but not least, at meeting room Grawiata is disease outbreaks and antimicrobial resistance.
The information regarding the place for this oral presentation already available on the newest program book as well. And if you have any further revisions for the abstract, kindly let us know. Kindly let the organizing committee know, and they will happily assist you with that. The organizing committee as well will show you the way to the places that have been written on the new program book.
And in the other hand, we already have 360 food sessions, so make sure you utilize that venue to capture this moment, and also
Exactly.
if you want to like to participate and learn more about the whole Bahagia Mosquito, there will be a tour session that you can join. If you are interested, you can meet at the meeting point in the registration center with staff wearing a blue vest from the Ministry of Health of Indonesia.
Yeah, and again, we would like to remind you to actively participate in discussions and interactions with both oral and poster presentations. We will meet again at 1 p.m., right, Mas Yopi?
Yes, for the oral, and also after the oral presentation and engagement with the other participant, we will join in the auditorium for the start for Symposium 5 for start the session about innovation in dengue control, bridging science and community action.
And do not forget, because we're going to announce who's going to be the most outstanding presenters, both oral and poster. My name is Rima.
My name is Yopi, and see ya everyone.
We'll be right back.